MedBricks Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Welcome to the MedBricks Webcast. This is Ramana Namaraju, and I'm the host of the MedBricks Webcast. So I have today's guest is Dr. John Silver. John Silver is a registered nurse and a PhD. He has been my guest for the beginning days itself. I've known John for a long time. He's one of the first few guests. Keep coming on my show. We had several problems during the beginning days. It's very frustrating. Now we solved the problem. But John is a very innovative thinker, and he is a nurse. He is an advocate for the nurses and the primary care itself and the healthcare system in overall. And he has great ideas of the policies. Then after that, I'm going to present a topic on for foreigners, particularly other countries, what the American healthcare system looks like in general. Just a brief 30,000 feet overview of the American healthcare system. And then I'm going to talk a little bit. I was talking with Dr. Stephen Lavalas about independent physician network, independent physician associations in the 1980s, 90s. I did quite a bit of work with them. So we have to revisit them in a sense that a lot of independent doctors want to be independent, but they need the tools. What kind of tools they need, and how do they make successful in their practices? I'm going to present a small topic and a couple of slides on that. And then after that, it's going to be exciting. And let me, bring a John Silver. His name is my old buddy. We argue a lot. Okay, welcome, John.
Hi, Ramana.
Welcome to the MedBricks Webcast.
How are you tonight?
Good. Tell me a little bit about your background. A little bit. Where did you? What is your until now? You got a gray hair, so you no hair, whatever it is. So tell me what you did so far all these years.
Well, this is actually my 50th year in healthcare. I've done everything from be a security guard in the hospital where I started to respiratory therapist for 6 years, and I've been a registered nurse for the last 40 years. I worked in every kind of hospital system except for remote rural type hospitals. Basically critical care, burn units, trauma, open hearts, surgical ICUs, kind of the adrenaline places. Went back to school in mid-90s and got my bachelor's degree in nursing, and then a master's degree in nursing after that. But I started trying to figure out kind of two questions. And the first one was why nursing couldn't control its own practice domains in the hospitals or in the states. We were still struggling at that point and still are today. But also, what's wrong with healthcare and how do we fix it? I spent the last decade of my practice as an emergency room nurse. So I got to hear all the stories of people that were coming in through triage of, why they were using an emergency room at 10 o'clock on Friday or, 4 in the morning or whenever the time was. So they'd opened up a PhD program. I wasn't getting any answers out of medicine or public health or nursing. So they opened up a new PhD program called the Public Intellectual PhD in Comparative Studies. It had been brought over from Cambridge. And I was in the second cohort of that class. And it opened up the opportunity for me to study health systems around the world. So I went to 3 different continents to study health systems directly. My first task was setting up what I thought the goals of a healthcare system had to be. I actually stopped for 2 years and got an MBA certification from Tulane so I could deal with the economics of it. I've worked with systems theorists and economists, health economists for 2 decades. And the idea, again, was to figure out which model around the world, if any of them, met all seven goals for a healthcare system?
Okay, let us talk about the economics a little bit. Let us talk about what is wrong with it. American healthcare system is a paradox. You spend more money and less access. It's a very strange. More you spend, less access the people are getting it, and less satisfaction people are getting. What is the reason for this paradox and a strange problem?
Well, when for-profit mentality gets into healthcare, they end up piecemealing healthcare out into a multitude of profit centers. So, and every one of those companies has an administrative structure that needs to be financed. A lot of them have boards of directors. A lot of them have LLCs over the top of them. They've got shareholders they've got to pay money to. So it just becomes this big sieve of money out of whatever community those facilities or practices tend to be in. We spend way too much money in this country, and a lot of that just goes up in smoke to people that already have a lot of money, and it's pulled out of the communities. And that's kind of the core issue of healthcare is it's transitioned into a money-making enterprise.
Unfortunately, the technology is also funneling the money to the top. That is helping them to funnel the more money much easier way. So if you wanted to you're a very transformative leader. You think very radical ways of thinking of fixing this problem. One of the things, what are the seven principles you're thinking about that you want to start a new model? Can you tell us what the seven principles you're talking about?
Well, actually, I can. I'll bring it up here real quick. We'll take a look at it.
Yeah, you don't. You just talk about it. You don't have to bring it in the. Okay, so just tell
Well,
us.
I like to be specific when I talk.
Okay.
All right. So the first goal was equitable, targeted, data-driven access appropriate to every community's needs.
Yeah.
The second one was that we're using quality evidence-based care. Third one is that using equitable, targeted, and evidence-based distribution of resources in a health system. The fourth one, and I thought this is one of the white reasons why I call it an adapted model, is that you need an interdisciplinary practitioner-led administration so that the system itself is congruent with those practitioners' values, but also so you can maximize everybody's skill sets. The fifth one is equitable and positive outcomes wherever you go into the health system. Cost efficiency is another one. And then the last one is social accountability and a mandate for direct public reporting.
So these are all policy statements. They are big policy statements, very impressive. But how do you implement this kind of a strategy, this kind of a policies? Is there any model that you're thinking about implementing this kind of a strategy for these seven principles?
Sure. So I came back from a variety of trips and meetings in UCLA with people from Southeast Asia and Korea and Japan and all that. And I set about collecting all the coherent models I could find around the world that had a coherent healthcare system practice. And I brought them all back and put them on the table. And one by one, I went through each one to see which one met all seven goals that I'd outlined. None of them met all seven goals. So I thought, well, let me look at our system, and our system didn't meet any of the seven goals. So the quintessential problem in the United States is that we have not had the discussion or made a decision about whether healthcare is a right or a privilege. If we consider it a right, then we're pretty much looking at some kind of national healthcare system. If we consider it a privilege, you have to be willing to step over the dead bodies of Americans. I don't accept either one of those. So, what's in the middle? And that's what I started asking myself. Let me ask US history, I said. So I went back through US history to find out, because we've had to have had a problem like this before, where something was too important to be just left to the commodity market, but we weren't willing to call it a right. And that was the issue of electricity as it was coming out in the teens and 20s and 30s in this country. The manufacturing base was putting out all these electrical devices to be used. And the unfortunate problem was that power generation was controlled in most cities by a small business that had a bunch of LLCs over the top. They charged what they wanted to charge and they went where they wanted to go, but it neglected huge areas in the country. So I looked at what Franklin Delano Roosevelt had come up with as a solution, which was the Public Utility Holding Corporation Act in 1935. So I studied that history back through the natural monopoly theory where it came from in England. And I brought the public utility model forward and put it on the table with the goals. And what I found was if I changed the administrative structure of how we consider a normal public utility, and I changed the financing model, so because you can't just have user fees paying for healthcare, that this model takes healthcare right down to the street in every community.
Yeah, very good idea. That's an excellent. I don't know much about that how the utility models work. So the money that you collect from the utility model, is it distributed among the communities, or the total money does distribution goes
No.
in the
So in the United States, we're a federated republic, which means you've got to respect kind of the federal state divides. So I set this model up in state based regional systems. The regional systems would largely be housed out of university medical centers so that the administrative council, which is again a lot of providers, would also have a tie into public health, to EMS services, to the universities, so that we could start making our healthcare systems a cooperative venture between academia, government, the healthcare systems themselves, the providers, so that we'd all have input and we'd all have decision making capabilities about how resources were distributed, what the needs in certain areas were. And again, it has to be every community. So it's rural, it's suburban, it's exurban, it's urban. We can't leave people behind.
correct. The consumers, we pay the electric bill, water bill, right? So they pay a medical bill that way, same similar way. That's what you're saying. So
Well,
that's good.
not exactly, because it wouldn't be a medical bill. So let's say, how much does the average person pay in insurance, for example, or how much is your employer paying to provide you medical service? All of those costs go away. You would have a flat fee, like on a utility bill of, let's say, $50. All your family, everybody in the house would be covered for any of their medical expenses that they had to do. There'd be no copays. We wouldn't need health insurance. There'd be no deductibles. There'd be no bankruptcies. And when we did the economic analysis of household payments, business payments, corporation payments, state payments, federal payments into these systems, we have more than enough money to finance these regional councils.
So yeah, that good point. That is a you made excellent point about that. There's plenty of money there that should do. But how do they get providers get paid? Doctors, nurses. How do the healthcare system gets paid through this process? Do you have a model for that?
Yeah, they'd be salaried.
Is a plain old salary.
Well, maybe plain to some people and a little plainer to others, but they would be salaried. There'd be no throughput pressure on physicians to have to see 40 or 50 people a day. The nursing could get out and use innovative delivery strategies in communities to meet the needs of people that live there with physicians. I'm not, it's not one versus the other. It's going to take all of us to do this. But you'd be able to deliver health services to communities and not worried whether you saw, 15 people or 150 people.
Are you taking the autonomy out of the doctor's decision making in this one because they are on salary? Who is giving that salary? Who controls them?
The
Doctors
regional
and
health,
nurses.
the regional health system would determine the salaries. There are going to be physicians that are going to take a cut. Specialty fees, specialty salaries, for example, have just gotten out of control. At the same time, primary care providers would actually, in most cases, probably have a secure income coming in that would again be respectful of the fact that they are medical doctors.
So if you're saying that there's a kind of a social mix of social, some of the complaint from the doctors is that we went to school for 20 years and we get paid. We have a lot of debt for them. Medical education is a huge debt they have. They can't pay with that salaries. You hardly, they after paying the student loans, there's not much left. How do you solve that problem?
Well, to me, the regional health systems would have a fund established that would actually cover physician tuition reimbursements. And it would require, and I think this would be fairly easy to do, a political process of restricting the amount of money that physicians would have to pay out in their tuition reimbursements.
What about the drugs, the medication payments, and all this? How does
Ah,
it work?
great question. So, the way it's set up now, Part D Medicare prohibits Medicare from negotiating drug prices. I know the current administration got the price of insulin reduced for Medicare patients. But when you think about it, type 1 diabetes, which is really the only type that really uses insulin, there's an awful lot of younger people too. So these regional systems can band together because they're no longer competitive. So while Medicare cannot negotiate drug prices, this regional system nationwide could negotiate drug prices and equipment prices and cooperate with each other. You have a tornado that hits 40 miles away. You can mobilize healthcare resources to come in from other systems to help them. Just like they do with electrical services when Florida gets hit with a hurricane. You have, electricians from as far away as Tennessee, public utility electricians come down to help us. So it would give us more of a health disaster response network capability than we certainly have now.
Who wants that equipment and the resources? Who are the owners of this equipment? MRI, CT scans. Who are the owners of that equipment? Is a regional
The
exchange,
regional health system.
system that there. So that is a governmental structure. That is a regional health system. Is a private governmental
Well,
kind of a private public enterprise.
yeah, in a way, they're state-based regional systems. They have their own budgets. In my system model, I have independent accounting services that work as their chief financial officers because we want complete transparency in what's going on.
So
But Romana, think about this. If I buy one MRI machine, am I going to pay wholesale or retail prices?
yeah, that's an excellent.
Retail.
Yeah.
If I buy 50, am I going to pay retail or wholesale? Wholesale.
Yeah.
Correct. So it's that same principle. I may need to replace my CAT scan. So I put the message out, and there's 15 other regional systems that need to buy CAT scans.
Yeah.
So we group together, we buy in bulk, and we get the discounts from that. Same thing for all the supplies, syringes, IV fluids, all of that. There's no reason we can't buy bulk. That's why Canada has lower drug prices. They buy as a national system. They don't buy as individual facilities or corporations.
What about you're being a nurse? Nurses are always a great patient advocates. They are advocacy. If you say the doctors, one of the complaints from the patients is that doctors lost touch with that patient advocacy idea. They are not advocating the patient's health. Now, nurses are always named as the greatest advocates for the patient's health. So, how do you enhance that advocacy and then empower the nurses more What is your plans in this, your model of utility plan? What is the role of nurses in this area?
Well, this type of service delivery is actually it's our grounding as a profession. If you look back at the 1800s and you look at people like Lillian Wald and Mary Seacole, and you look at the initial uh, ideas of what nurses had of what we need to do, um, this is really reconnecting nursing with its past. And this is what, a lot of people don't understand about nurses is we're not financial driven, we're mission driven. And if you give us that opportunity and, give us that independence to work, you're going to find a whole bunch of, there's over 4 million of us in this country. You're going to find a lot of nurses that want to come back to practice.
What about the nurse practitioners? Some of the states allowing nurse practitioners to prescribe medications, and some of them are on work autonomous. Some of them are they have to have a medical director. What are this? What is going on with how many states, and what is this grand mixture of? There's no national policy. Tell us a little bit about the nurse practitioners' role in this one.
Sure. Well, this model actually does require that NPs be allowed to practice independently in all 50 states. We have that power now in 24 states. We've got a little bit of a hybrid practice in another 3, so we're over half the country now. This requires legislation since nursing practice is regulated at the state level. We found in a lot of states, the biggest obstacle to doing this is actually physicians who have been, mired in what I called a kind of a guild relationship with their profession. Healthcare is not a zero-sum game. Just because nurse practitioners gain independent practice doesn't mean that physicians lose anything. Nobody's trying to demean the practice of medicine or say what it isn't. But medicine alone is not going to be able to solve this problem on a national level. It'll take all of us working cooperatively to look at what's needed in communities and then figure out the best way to bring that service in.
What is in the regional exchange that you're talking about, regional utility kind of thing? How do you incentivize people to go into the rural areas? People don't want to go into rural doctors. I used to place the J1 doctors unless they're forced by the law that they need to work in the rural areas until they get a green card. The, how do you force them to go to the rural areas in your model?
Well, I don't think you can force anybody to do anything. I see healthcare in particularly a lot of these rural communities as kind of a springboard for other opportunities. So, for example, let's say you've got a remote farming community and we go out and evaluate it and decide that, yeah, they really need some kind of rotational clinic services through there to see the kids and farm workers. And so you can either use existing structures in these communities that have been, dormant for a couple of years, or the state could use eminent domain and come in and take 5 acres and we build a little clinic in there. So you've got that health kind of clinic building going on. But there's no reason we couldn't bring in, for example, Wi-Fi to some of these communities that don't have it through that structure, and offer training programs for trades or school or university contexts for people in that community to develop skills. We could also use that as to bring in part of the Department of Agriculture assistance. It doesn't have to be there 7 days a week, but the Department of Agriculture to come in and help the local farmers and help them with crops and pest controls. Um, you know, so there's other services that can piggyback on that presence of healthcare.
Yeah, that is. I used to place a lot of J1 doctor in the USDA, United States Department of Agriculture program. I used to place in rural areas in California, in Georgia, Alabama. I place a lot of them. The problem is, it's always, I found more nurses in the rural areas. Doctors are not willing, the moment they finish their period, they're required in a small area, in a rural areas, they want to go back to the big city. So how do you incentivize these people to stay in the rural areas and practice more, both nurses and doctors?
Well, from nursing's point of view, it would because that's the people that need help. I mean, that's really nursing's kind of mission. Find people that need help in healthcare and help them. Our goal is to build healthy communities, not just reduce disease. So, because the more you build a healthy community, the more you work on the social and economic contributors of disease. If you can kind of think of it this way. In my mind, healthcare is one of the few businesses which should be striving to try to put itself basically out of business, and that's kind of unique in American businesses.
Yeah. So, John, you have a lot of challenges ahead of your plan. It's a very noble plan. It's a big plan, and I don't know how many. One of the biggest obstacles is the money and the power and there's a lot of political and financial and more. There's so many other factors you need to really. What do you have a strategy that how do you proceed in the with your plan?
Well, absolutely. We formed Nurses Transforming Healthcare 3 years ago to try to get this off the ground. It was just a couple of nurses at that time. And we've slowly been reaching out over the years, contacting, attending conferences, presenting, making sometimes individual contacts, sometimes group contacts. There's over 800 groups in the US just at the nursing level, all trying to address this kind of issue. There's medical groups out there, there's public health groups out there. The thing that's been lacking, I think, is the vision, the end vision that they see to be working towards. So if you're always trying to funnel everything through an allopathic for-profit system, that may not be what the community wants. You have to go in and do the proper assessment of a community, which we're not doing. For all due respect to public health, they've been doing these community assessments for 50 years, and we're seeing healthcare and health go backwards in the country. I use a nursing community assessment tool, which I've been graciously given the rights to use by Dr. Gene Watson at the University of Colorado. Because what I've found and what a lot of people have found in research is that something like 95% of these community needs are actually nursing needs, not medical needs. And then if you combine nursing with things like nutritionists and physical therapists, and let them practice to the scope of their practice. And remember, a lot of these groups, this isn't 1920 anymore. A lot of these groups are working at doctorate level training in their professions. So why would we handicap them at that point? Let them go out and do their practice. Connecting with pharmacists, which is often a neglected group. There's other specialties out there that are ready, willing, and able to help if we give them the structural opportunity to do that.
Nursing, you made an excellent point. Nursing needs are the more they require more nursing needs than medical needs. Excellent point. I think that is I wholeheartedly agree with that point. So let us see that how we can. I'm going to present a topic on the overall healthcare, U.S. healthcare system, and particularly people who are in India and other countries. They don't know about American healthcare system, how it works. I just over 30,000 feet kind of system, and I'm going to talk about briefly touch on the independent physicians. They're raising a lot of voices. So let us see how we can empower them with our system, including the nurse practitioners by chance. So I'm going to present that topic, and after that I come back. I'll ask you how they can reach you and what kind of support you need from all these people. So let us
Sure.
come back and let me present that topic. You and me watch. You can jump anytime. You can make any comments together. That's not a problem.
Thanks.
Just let me, yeah, both we are there. Okay, see, so that is 30,000 feet. I'm going to talk about healthcare system in general. So this is one of the jokes in the healthcare in the quantum physics is if you think you understand quantum physics, you don't understand quantum physics. So I say they repeat the same thing in a system. If you think you understand insurance, you don't understand insurance. That's what it is. So that is really that is a complicated process. So just to let me bring it my system here, and I can follow that because my eyesight is not is okay. So there's now let us talk about the American healthcare system. U.S. population divided into the insured, uninsured, uninsured. You know that they have to do. So let us talk about insured one. Public insurance is Medicaid. And Medicaid is the people who do not have a income enough, and they're young, and those people who don't have enough in the below the poverty line, they get the Medicaid eligibility. Medicare is the people who are seniors, 65 and up, they get the Medicare benefits, and the other public things that John may know, some other public thing. He wants to put the public utility kind of thing there. The other one is uninsured. The private insurances are, the employee sponsored, the payers, individual plans, the PPOs, and all these things, and exchanges. So there's a whole bunch of people that there. So just I'm giving you a very brief tour of this system. Medicare is a federal 65 and older. There is a four parts to it: Part A, Part B, Part C, Part D. Part A is basically deals with the hospitals. Part B is the doctor's visits and doctor's offices. Part C is the Medicare Advantage plans, which is a kind of a health and maintenance plan. See, Medicare Part A doesn't cover dental or vision. So Part C covers the Medicare Advantage plan, covers both medical and the dental and vision it covers. Part D is the prescription drug benefits. This is a complicated way they put together those four parts to the American healthcare system. Then, then Part A, let us talk about Part A. So they are run by DRG, Diagnosis Related Group Payment System. They call DRGs. It's a very hospitals all follow these ones. They follow ICD codes. The International Classification of Diseases. All the diseases are classified. India should do that. India doesn't have the classification of diseases. We need a uniform diseases. A lot of countries don't follow. We need that badly. ICD 10, ICD 11. These are all versions of these ICD codes. So these are all like, for example, heart failure is a diagnosis code, and newborn babies. All of them are based on DRG. The next one is I want to tell you very quickly. So Part B is a lot of doctors bill insurance companies. That is doctors visits. All of them are CPD code procedure. These are procedures. X-ray, for example, is a procedure. You bill it for X-ray. ICD is a diagnosis. Pneumonia, bronchitis. You say that, and then you do chest X-ray. That's CPD. So base CPD are procedure codes. Outpatient office visits. There are different levels. Are huge. That itself is a huge administrative tasks involved. So the next one is Part C. Part C is Medicare Advantage plans. It's kind of a lot of there is so much talk about Medicare Advantage plans. One of the benefits of the Medicare Advantage plan is they cover the dental and vision. Part A doesn't. Pure Medicare doesn't cover that. But some of these advantages, we don't have enough data that is working or not. There's a good criticism, and some people love it, some people don't like it. Still, we don't have enough data to comment on the Medicare Advantage plans. But that is a new thing. A lot of people are coming up with the Medicare Advantage plans. Maybe John can say something about Medicare Advantage plans. So, what do you think of Medicare Advantage plans, John?
Well, you end up having to pay more money. Um, so, I started paying into Medicare back in 1968. Um, so I hit the retirement age. And now, if I want this other stuff, I've got to pay more money now to get that. Well, that's great unless you're living on a fixed income and you can't afford it.
Yeah, that is a criticism that he's talking about. So John lives in Florida. Florida is full of Medicaid patients,
Yes, including myself now.
including yourself. Yeah. Um, then the Medicaid is a state funded program. Is a federal and state combination together. It's a low income poverty line. Before the poverty line, hospitals
But
and doctor visits, they pay a particular fee. Okay.
this was put in on the auspices of dealing with what they called the donut hole, where you had people taking two or three meds, and then you all of
Oh
a
yeah,
sudden had
pharmacy
people
benefit. That's
taking
what I.
8 or 9.
Yeah, sorry. Yeah, pharmacy
Uh,
benefit. Yeah.
but the giveaway in Part D was they prohibited Medicare from negotiating drug prices. So that's the way they got Big Pharma to back it.
There is a movement coming in right now. There is a new law passed in that you can negotiate the prices with the Medicare now. That's what I understand. Executive order. Is there anything in the cooking in the?
Not unless they've gone back in and changed. I can't remember what it was, Title 19 or something of the Part D Medicare. So unless they've gone in to change that, I think it's still the law.
So this is not a this is an example of not a free enterprise system, right? Free enterprise system, you have a freedom to go negotiate prices, but here is a pharmacy benefits for one. It cannot negotiate the prices. Whatever the pharmaceutical companies say that you have to take that there is not really a free enterprise system there, right?
Well, yeah, and one of the reasons that benefits managers, the PMBs or PBMs or whatever they call them,
Hmm.
the pharmacy benefit managers, they sold that idea thinking that they could get the lowest, best price for people for their medications. And what they really did was just create another monster that's taking money out of the system again. And they're ending up really doing serious harm to local pharmacists.
Yeah. I agree. I mean, this is the whole thing is funny stuff. So Medicaid is a hospital visits, as you know, that they're all paid one price, and then you cannot bill anything any patients. So I'm going to talk about a little bit of so who manages these plans? Tech companies. IBM used to manage. John Ross Perot used to run a EDS. That's a very beginning days. I remember from Dallas EDS, Electronic Data Systems. They are the first company used to manage the plans. They administer the Medicare plans, a lot of state insurance plans. So a lot of technology companies are really bidding. United Healthcare is one of them, and a lot of insurance companies they manage these plans. So they're carriers, and a lot of them are these are public insurance companies. The government insurances carriers they do that. There are in the United States they give it to the administer these things through the third party carriers like Atma. They have their own products, plus they still can carry Medicare and Medicaid. They can administer that.
Yeah, the problem is, again with this is there aren't many hospitals that can survive on just Medicaid patients. And there was just a story, and I don't remember where it is, where the DOJ is investigating, I think, United Health for antitrust.
Yeah,
So what we keep seeing are the mergers of these companies and then a dissolution of services.
yeah.
That's problematic.
So premium health savings account, that's a very private insurance private payers. So this is the Silicon Valley. I mean, there are all of them. A lot of them have a premium health savings account. They pay from their pocket. They can decide. They give up freedom. Consumers feel that they have some freedom to spend their money. They save some amount, and the company puts some amount, equal amount, or whatever they agreed upon. Then they spend that money on their own. The consumers have the choice how do they spend that savings account. They can go to psychiatrist, psychologist, or any other therapy sessions. All of them they can be using for these kind of things. So health savings account is a very very common in particularly in the kind of neighborhoods that where the economy is good. So the health savings account is very FSA, HSA they call. So
Well, it's your money going into it. Why shouldn't you be able to spend it where you want?
So there is a lot of different models now. Fee for service model is one of them. So that means you go to your doctor's office, he bills the visit for that visit, office visit, and then he does X-ray. You will add another service. That is you can bill it. That is a one model. Fee for service model that is kind of dying down. There's a fee for service model. So they bill for each procedure, each visit encounter. They can bill it. Okay. The capitation model is a flat fee they pay per month this much, or flat fee for the procedure itself. So it's a very combination of so many things there. But in general, capitation means they give a one price, one per member per month. This is that they pay. Whether how many times you see it or not, that's your risk. Concierge medicine is just to play cash. So just go there and see him and pay. Some people now they say this copay is becoming almost concierge pay equal to concierge pay. So you don't need insurance. You can do all those things except catastrophic insurance.
Well, except most of them are primary care services that you're getting. And, that doesn't help you when you need a liver transplant
Correct.
or you're in a trauma accident in your car.
So why
So
can't they
you
do?
still need to carry major medical.
Yeah, major medical, but catastrophic insurance only pay for the catastrophic insurance. That would be good, right?
Right.
So only catastrophic insurance is where major medical requirement rather than for every office visit, every cold and cough. You don't need insurance plan to get into the process. The
And, and one comment on fee for service. Um, a lot of doctors are now employees of the facilities. You're not going to see much fee for service in a facility. And
well,
the fee for service practices that have been out there have really been purchased a huge amount by venture capitalism.
yeah.
So they sell their fee for service practice and they, become what?
John,
Employees.
there is another reason people are not talking about it is that hospitals are buying these practices because they tell the doctors that we get paid facility fee. That's a huge amount. So you don't get paid. If you join with us, you can split that fee. Eventually,
Right.
you can make more money. We pay you more. But that's a trick to it. That's a danger to it because a lot of doctors who did that they bought them and then eventually they got kicked out. That's one problem. Second problem is how do you know that the government is not going to pay attention? Insurance companies don't pay attention that you're saving a lot of money, so they're going to cut down that price also eventually. So it is not
Well,
that this is not a sexy as look like in the beginning, but it's a potential pitfall there in the selling
and it
the.
and it can be very unstable because health systems can be bought out by other health systems, and now suddenly you've got different management coming in, renegotiating things. So it's not exactly a very stable
Yeah,
environment.
well, correct. So let us say I'm going to give us some small mathematics here, math for the complicated Medicare payments. Medicare pays say you bill the doctor bills on his profile basis. I'm a special diet doctor. I'm going to bill for $100 based on his profile because I'm highly qualified. I want to pay more. I want to get paid more or whatever it is. That's a based on profile. The total bill they send it. Medicare in turn says that they authorize $80, for example, and then they pay 80% of the $80, $64 that they pay. They tell the doctor additional expenses that they encounter doctor to collect that other $16 from the patient. If we don't collect it, it's also illegal. You have to collect it. You have to you have to collect that money. You have to have a plan to collect that money. So it is a very complicated way to math. In Medicare, so the authorized amount out of the authorized amount they pay direct Medicare. I'm not talking about Medicare Advantage plans. Maybe Medicare Advantage plans cover all the 100%. I don't know about it, but they have so many mix and match. We don't even mind-boggling in my view. So that is a Medicare reimbursement structure in general.
Uh, well, again, pre-approvals are required. The docs have to document all the rationale for why they want to order a test, and they can always come back and just say, no,
No, yeah,
we're not
correct.
going to cover it.
So there's a lot of third-party administration. There is a self-insured ones. This is a really good. I want to talk about the independent physician networks. There's a lot of. I can tell you this is the where they can tap really potential these independent physicians and the independent nurse practitioners. These self-insured. A lot of cities, counties are self-insured. A lot of Delta Airlines, Delta, the IBM, they're all big companies are self-insured. Even small companies are coming in the picture. They're getting together, banded together. They're getting self-insurance. They're bypassing the insurance, traditional insurance companies. That is where independent practitioner can excel. I tell you why. Here is a model I'm going to tell you. So, independent physician networks is a very getting popular now. I was talking to Dr. Stephen Lovalis. He's talking about independent physician model is coming back. He says, I agree with that. There is a potential benefit for the autonomy of the physicians if you want to get it. It preserves autonomy. The doctors can make decisions in there. That's the biggest plus. Reduce administrative burden with the independent physician associations. They're all independent doctors together form a club. It's a co-op, so they can reduce the common costs, billing, and the billing costs, administrative costs. They can drastically reduce it. I used to go to the doctor's offices. I used to see every doctor in the back. I used to hear the schemes from the back office with the insurance companies. So that at least you can avoid with these independent physician networks. They can do side of the place. You can have pleasant atmosphere in the doctor's office. So increase the bargaining. When you are get together, you have to watch out the antitrust laws, of course. There's got to be careful. Power of potential for cost savings. There is a co-ops. This is the last one. I love it. Co-ops. There's a group purchasing organizations. We did that. We bought a bunch of Lexus together, and actually we started band together by the doctors. So you can do as a group. They are get together. All these providers get together, start a form a group. You can just John was talking about purchasing MRIs. Maybe it may take you some more time to really follow the John's plan, but you can plan with the co-ops, independent physician networks. You can do that now. The co-ops are very powerful. You can bargain large number of things together. You can buy everything in a large quantities. So co-ops, GPOs, very powerful but independent. That's a plus. Let me tell you about the disadvantage of the independent physician networks. Lack of unity. I used to we tried as independent physician networks. The doctors fight all the time. They say that doctor worked much harder than me, and then you're giving the same amount of money to the guy. It is just that is a lack of unity. They took advantage of the insurance companies, took advantage of the lack of unity among the doctors. It is important that you need to be on the same page. So membership costs is one of the problems that you need to pay for the lawyers and all those things. Implementing the cost, that is a little bit cost involved in the membership. The main thing I learned from Gary Matthews, he passed away, rest in peace. He's a great guy. He taught me how to, this IPS, he used to set up a lot of IPS. He taught me during the 1980s and 90s. So what that is negotiating is a key. You have to understand that really negotiating, you have a savvy of the negotiations, that you have to have a little political cloud, a little bit of everything you need to have, legal aspects, everything you need to cover. So that's negotiating is a big challenges in that area. But I tell you, opportunities. Independent physician networks can do a lot of things. They can tap the health savings account. This is a very young people need really help. They want to spend their own money on their own basis. You can come up with a plan together. Bunch of doctors get together and say, we're going to offer you this price. All the HSA, if there is a big company in that area, you can offer them together a HSA, a comprehensive plan. Really works very well. Then cities and counties. Actually, I went to the county. I don't want to mention that, actually I can mention city of Atlanta. We went there. We spoke with the benefit managers. But, the problem is, I'm not talking about Atlanta is a great city, that we have a great mayor. But sometimes we have these benefit managers are lazy. They don't want to do anything. We already settled everything and we don't want to do anything. This is actually the problem is benefit managers, or they need to open up if they want to reduce the cost of the healthcare. Most of the cities are big cities and counties are self-insured. You can tap that market and tell them we can provide a primary care to them and then reduce the cost of the whole overall premium. You can take reinsurance, Lloyd's of London or something like that. You can take that. You can really risk. You can do partial risk or full risk. You can do that. You can save a lot of money to the city. And if you give a good proposal that you can save money to the city, they'll love to hear. So they will be on your side. So there is an advantage. Independent physician associations can do that. So talk with the city and county. They are self-insured, and you show them path to how to save a lot of money on the premiums, because you can drastically cut down that only emergency care. You go to the because they're self-insured anyway. Then that one of the problem with the city and some of the self-insured companies, self-insured cities, is the retirees are large number. They are taking a lot more money from the present system than the people working there. Retiree employees from that city. So you can come back with a plan that address that one. It's a very beneficial. So independent physician, including nurse practitioners, can do that. Negotiate with the city, or a lot of self-insured companies. There's a lot of them out there. Or even you can propose yourself, self-insured companies, and say that, why don't you do self-insured? Even a smaller level, you can do that. Risk retention groups are there. There's quite a bit of them available. Now they have a lot of tools. You can take full risk contract and partial risk contract. So you can do all those things. So there's a lot of, the act, the Obamacare is Affordable Care Act. The disease protocols that they came up with it. Value-based care is based on the Obamacare. But the Obamacare has negative things also. It increases the premiums for some people. So it's really, we do not have a strategy to cut down. I personally feel that we need a both combination of the free enterprise system. First, you quantify the healthcare system. We don't have the quantification of healthcare system. What I mean by quantifying the healthcare system. So quantifying, just let me put that word on before I pass my talk about that. Quantifying the healthcare system is you have to quantify the doctors, nurses, personnel, all the resources, including the equipment, everything what is needed. Separate them all. That's a physics system health. How do you do that? You defragment everything and put them together. You will be surprised at how much money you can save by defragmenting the whole process, untie the process, and then put them together as it needed. It is it's a mathematical tool, excellent work, and then it does save a lot of money. So you defragment it and then quantify the healthcare system at the granular level. If you do that, really there's a great potential when you put it back together, when you need it. You can take some parts here, some parts there. You can put together. For example, I'll give you an example. MRI. If you have an MRI center, you got the doctor, you need a radiologist, you got a nurse, you got a medical assistant, you got an injector, all the supplies. You can quantify all of them separate. Then if you are buying a contrast, all the MRI companies in that state can go and negotiate the contrast a lot cheaper as a group purchasing organization. So it's a lot of and also you can negotiate with the technologists and all those things. So it's a lot more power by defragmenting quantifying the healthcare system. You can do a lot more things. So there is a lot of agencies, federal regulatory agencies out there. It's a highly regulated American healthcare system. There's a laws, HIPAA laws, privacy laws, patient rights, stock laws. Stock laws I want to comment on that. A lot of doctors also been confused about stock laws. Stock laws are, Peter Stock is from California. So stock laws are inducement of referral. If you whatever the system is, they think, if you put your brother-in-law as a owner, that is still inducement of referral. You are getting the family benefits. You have some way back to money coming back to you. unless you show them arm's length deals and all of them, a stock loss has to be watched. That's the one thing that a lot of times doctors get into trouble. HIPAA laws is a privacy laws. That now there is a bigger problem with technology companies. They're that one of the companies that biggest problem recently was Equifax. They 100 million people privacy. The thing went out. Big problem there. So prescription laws, there is a lot of prescription laws. The Schedule 1, Schedule 4, Schedule is just a mess. And the antitrust laws, that you cannot get together, all the IPAs get together and negotiate the prices. That's a violation of a law. That's what they say. So it is a kind of a complicated agency regulatory framework is there. So if you want a medical devices, you have to go to FDA. Some of them are 510K approval that they already existed. 510K approval means the technology exists, but basically you're putting a different technique there, different equipment, but the process algorithm is same. So if there is a 510K approval, you can get it faster. But the Silicon Valley people don't understand is this is the one they get into this problem with them. So who pays for it? They don't understand it. The Silicon Valley people, startup will solve all the problems, but they have to understand who is going to pay for it. Is the insurance is going to pay for it? Doctor is going to pay for it? Consumer is going to pay, patient or brother-in-law is going to pay for it. If somebody has to pay for it, right? I can tell you only you end up with your brother-in-law, you end up paying for your brother-in-law. That's all it is. There's all those people, most of the time they don't pay. So you have to, there's a big fight in front of you to get paid from these companies. So don't take for granted. A lot of Silicon Valley companies take that for granted. One of them will pay. Unless you are really sure about who's paying for you, don't start the project in that sense. So this is a brief tour of health insurance. Thank you for watching. Let me bring John back there and let him comment on the system. What do you think of John?
Hey.
What do you think?
It's a system that's complex because it designed itself to be complex.
Yes.
The delivery of healthcare is not really complex, but the systems that we've let evolve since the 70s, particularly the corporate systems, have required supervision. Governments tend to be reactive in legislation. So why do we have EMTALA laws? Well, because we had hospital emergency rooms refusing to see patients because they didn't have insurance. Why do we have HIPAA laws? Because we found out there were companies selling patient information to other companies to get. So there's just so many regulations in healthcare because it encompasses so many different things, not just the technology we're in, but as you pointed out, the relationships of physicians to other physicians. We found out, for example, when physicians owned hospitals, that there were frequently Stark Law issues that were brought up in how physicians were referring to each other. So we've sort of let this system evolve since the 60s and 70s. And then once, corporate and venture capital saw how much money there was in healthcare, the last 40 years have reflected that.
You work as you're a nurse, you're a leader for the nursing industry. You're a great voice.
Oh, I don't know that I'm a leader, but
you're a great voice for the nurses. So there are a lot of nurse practitioners are doing a lot of practices around the country, independent practices. So I want them to be powered by technology and then a lot of equipment, medical, the evidence-based medicine. I'm showing you one example of this particular device. It can do 7 vital signs: EKG, blood pressure. You don't need cuffs. Without cuffs, it can do the blood pressure. It can do EKG, single channel EKG. It can do oxygen saturation levels. You put this one there in the finger and put in the mouth. In 30 seconds, all the respiratory rate, everything comes out of this simple device. Use this one and goes to the platform and then if they have questions, they can ask a doctor online. So they can empower, the nurses can empower in rural areas, in big cities, use the technology, use the resources. They can do ultrasound. Nowadays, ultrasound is a small iPhone comes there. You can do like a pictures with ultrasound, take a pictures and show it to the doctor online in real time. You can do that. Then X-rays, they became a very small X-rays now with the battery operated X-rays. So you can rural areas, you can implement it. So a lot of nurse practitioners that they can make even more money in a small rural areas with this one. Independent doctors, they can do all these things. So evidence-based medicine, that they can implement all these things. John, how do they reach you? The people, the nursing community want to reach you. What is your website?
Well, my association group, or my 501(c) is called nursestransforminghealthcare.org. It's all lowercase, one word. Nursestransforminghealthcare.org. If they'd like me to come in and talk, they can either reach me through that website, or they could email me directly, forrester2232@gmail.com. FORRESTER2232.com. I've been to probably 4 conferences in the last year. This is really starting to pick up. I think more and more healthcare providers and nurses don't want to go to a conference and hear a keynote about, meditation. I think they want to come in and hear what some options are in healthcare that can help them reground themselves in their professional values. And I think that's what I talk about.
John, I have always respected you. You are really noble person trying to do good things for this country and communities that you live in. So I think I have utmost respect for you. I disagree sometimes, argue with you, but I know you for a long time. We've been friends, and we've been coming on my podcast for several times. Thank you for coming. First time we had no problem, no glitches.
No
All
tech
is good.
problems this time.
It is.
Well, the
Thank you so.
respect is mutual, Romano. The respect is mutual. I love
Thank
some of
you.
your shows.
Yeah. Thank you so much, John. You're a great asset to the American healthcare system. Thank you all. Good night. And then next time we'll bring John to the one of these big events, and then we will put a conference together, all of us. So thank you all joining with us, and I want to see you guys. Good night, all of you.
Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.